hey guys, I'm glad you're here. Get these passed out real quick. Give you a little background with me. People say, talking about Matt, coming out to a club and stuff like that. I came into chiropractic school without any background whatsoever in human anatomy, biology. I was let in as one of the new alternate program. It was the first Tribe the alternate program. So Tribe 1 was like incredibly hard, it's been kind of an uphill battle while I've been in chiropractic school. And so, of course, just to make things easier, I meet this guy named Jason McCloskey when I was in Tribe 2. And Jason, and honestly, I was at a point where I was a little frustrated with the program. I had come into chiropractic. My goal of coming here was, my background is doing a lot of international missions and relief work, and I worked in post-tsunami Thailand for many years. And so I had been accustomed and had a background in seeing a lot of people with tremendous suffering, particularly musculoskeletal issues. And so we came back stateside to finish the adoption of my Thai daughter, and I came to discover that, and I found out about Parker University and that they had this program here. And at the time, I thought chiropractic was about musculoskeletal injuries. And so I thought, wow, 3 years, I can learn that and then go back to Southeast Asia and be able to be of some help and assistance there. And so I came here and I found out that chiropractic is actually much more than that and isn't necessarily really focused upon as much on musculoskeletal injuries as it is about, a lot of wellness as well and the nervous system. And I found that interesting, but I was concerned that I wouldn't be able to really apply it in a relief work kind of setting, and what I was looking at. And so I met Jason. And he begins to then tell me about chiropractic neurology and this place called the Carrick Brain Center that he worked at. And I looked it up, and it blew my mind. And I saw, wow, there is something really cutting edge and new that's happening in chiropractic that, I have a burden for people that are suffering in some huge ways. I like being in the trench warfare of human suffering, to be honest with you. I think a lot of people that are called to this feel the same way. That you really want to work with people that have lost all hope. And I saw the hope that comes from what you guys are spending some extra time coming here and doing in this room. And I appreciate that. And I know, chiropractic school was an uphill battle. It's been an uphill battle for me from day one. And so I hear people saying, man, I just don't have time to do it. And I'm like, you know what? The minute you realize and you see what impact this has upon patients, and literally the families that are just in tears from the miracles that are performed, in the clinics and with the doctors that are doing this sort of thing. And it's not just a random every now and then kind of occurrence. It's every single patient that walks in the door, and to realize just what God is going to do with what is starting in this room right here. That's worth 24/7 to me. So come on in. All right, so anyway, that's my quick sermon. Let's get going. Let's talk about the big picture of functional neurology. And this is how my head works. I like to see exactly what's happening when I see a patient come through the door and how I'm going to be able to help them as soon as I get this to work. Full screen. Full screen. There we go. Oh,
here it's coming.
All right, there we go. Nice couple. You must my wife. So anyway, so what we have. Oh, didn't expect that. All right, so big picture. What we do with functional neurology is first we have our patient history or some sort of change in presentation that happens. So let's say I've got a patient that I've been seeing in my chiropractic clinic for some time, and suddenly something begins to then change in that patient's life, especially if I've got a relationship with them and I'm adjusting them regularly and I'm getting to know them personally. I find out that all of a sudden maybe they've had a tragedy happen in their life. Or maybe they've got a relative of some sort that's beginning to have memory problems, or they themselves are aging and beginning to have that. And I've got something that's changing there, and I notice that with my patient. Or when I have a patient come into the door, and it's the first time I've ever seen them, and part of their presentation has things in it that maybe they came to see me for a musculoskeletal issue, but I'm looking at their history, and I'm seeing things there that also make me think that there may be something even more insidious happening within their brain. And so I see that and I go, you know what, I want to investigate it further. And so then as part of what I'm doing then is I'm going to do a neurological exam on that patient. And this is something that if you haven't gotten to Tri-5 yet, you will learn this in Tri-5, how to perform it. You won't necessarily learn how to interpret it yet or how to do therapy based upon it. But you will learn how to perform it, and that's the first step in what is one of the most important parts of what we do. And so you're going to perform this neurological exam. A neurological exam will take about 30 to 40 minutes to perform, and that's if you're pretty comprehensive. And it could take up to an hour, or you can do it in just a few minutes if you had to, but about 30, 40 minutes. And you're going to then go ahead and you're going to identify deficient parts within the brain or the brainstem. And you're going to break that down. You're going to go, okay, where are the deficiencies at? And that's something you're going to learn in Try 4. When you take neuroanatomy, you're going to learn about the brain. You're going to learn about it probably in far greater detail than is necessarily going through the head of of your peanut butter and jelly basic patient coming in the door to a functional neurology. But most of all, you are going to think big picture with your anatomy, and that's going to happen in Try 4. And then Neuro Club, and that's where you learn to take the neurological exam and you really localize where the problem is within that person's brain or brainstem. Then we're going to activate those regions. And you're going to activate those regions either in your clinic or you're going to send them home with exercises. We cover this in Advanced Neuro Club. And so, I've seen it done both ways. At Cerebrum, what we do is, we'll see a patient for a solid week, maybe even 2 solid weeks, and you're doing all of their therapy right there in the clinic from 8 a.m. to 5 p.m. And that's an amazing way to do it. Another way you can do it, I've seen this happen with Dr. Stangl in Chattanooga, and he does it where he sees his patients. He'll only see them for maybe 5, 10, at most 30 minutes, and then he sends every patient home with exercises to do. And they do those exercises, and at first he'll see them 3 times a week, and then he tapers it down to 2 times a week, and then once a week, and he'll do that over a period of usually just maybe 2 or 3 months, 4 at most. And that's how he goes about doing it. And it's the same sort of thing that we would do at Cerebrum with the staff there, but stuff they can do at home. So that's how you can integrate it into more of your traditional chiropractic practice as well. And then finally, you recheck and modify that neuroplasticity as it takes hold. And so you just go through and you look at, you go back and you do neuro exam again, and you see, okay, hey, we're beginning to see improvement, or we're not. We're going to make some modifications. And we'll continue to make it happen. You'll be astonished how fast the results will come. That's the one thing that really blew my mind with this, how eager the brain and the body is to heal. All right, so let's just go ahead and review real quick. Where do we target these therapies? And so when we're going through and we're targeting these therapies, big picture thinking, I'm going to the right or left side of, first off, the frontal lobe, right up here. And so my frontal lobe, that's primarily responsible for consciousness. Let me check on my dog real quick. Okay, my dog's going to live. All right. My dog's in the emergency room, by the way, if you didn't know. Thank you, Jesus. All right. And so we're going to check the frontal lobe. That's one area that we may target in therapy. We're going to do maybe the temporal lobe. For those of you that haven't had neuroanatomy yet, I'm just kind of giving you a quick overview here. Your temporal lobe's over to the side. Temporal lobe, broadly speaking, is responsible for a lot of memory. Of course, there's more things that these lobes do, but just giving you a big picture. Occipital lobe, right back there in the back, that's sight. The parietal lobe. Parietal lobe, for the most part, think body position. The big word we use sometimes is called proprioception. Your vestibular canals, those are right behind your ear, right here. And those are responsible for maintaining and being aware of when your body is moving, particularly when your head is moving. That's when you'll see things like if you ever go to the Cerebrum website, we got that cool, it's called a gyrostim. Put somebody inside of a seat, start spinning them. That huge machine to do that, this is a different one. Frankly, I think it looks even cooler, just to activate those little canals. But it's astonishing where they're positioned right inside the brain, the kind of activation you can do by just by activating those little canals, miraculous. Your cerebellum. Cerebellum is responsible for coordination of your movement. And let's go down to the midbrain. Sorry, I don't have my remote today. Can you all see that? No. Oh, yeah. Did it come in there? There it is. All right, so your mesencephalon. Your mesencephalon is right here. It's also called your midbrain. Okay? That right there is responsible for the most part, your sympathetic response. Okay? So that's fight or flight, very primal. Your pons and medulla, right here. It's also called your PMRF. That gates this bad boy and is responsible for your parasympathetics. And that's simply the effect of slowing down your sympathetics. All right, and then we do have systems that involve multiple lobes. And then whenever we do those, we just stack our treatments based upon which lobe is the sickest or which part of the brainstem needs the most therapy. By the way, anybody, if you got any stuff to add, don't hesitate to jump in with this. I think most of our audience tonight is already familiar with most of this, so I'm just going to kind of get through it real quick and we'll get to the good stuff. But yeah, you got your limbic system, your basal ganglia, you've got memory, all kinds of different systems that do just kind of stack upon them, and that's not necessarily going to throw you with your treatment. It just means you got to prioritize and stack them up. All right, so there we go. So why the eyes? Why are we so interested in the eyes? Well, embryologically, the eyes are actually brain tissue. I love this. All right, and this is really fun. I love when we tell this to patients, actually, when we're in the clinic. Because a lot of times they'll ask, why are you just moving my eyes and doing so many eye movements with me? I came here to get my brain fixed. And that's a common sense thing to say, and then you tell them, well, here's what happens. While your brain is developing, these eyes begin to then form right there within the brain, and it is brain tissue, and they bud out. And so literally, when I am looking into your eyes, I'm looking into your brain. All right, so if you can think about the eyes that way, I'm staring at the brain itself. And so it's the most amazing thing that God did, that where I've got actually a window right here. So I've got all the protection in the world for this vital organ within me that runs everything, and yet I've got these awesome portholes. All right, and so then when I look inside that porthole and I see that brain tissue, every time it does something weird, I know that there's something wrong with the brain tissue itself. Also, that's my window to treat it. All right, and so it's incredible. So what you're learning tonight is you're learning literally to physically treat the brain. And that's the power of the eyes. Tell your patients that, and then suddenly having them do little head movements and looking around with their eyes suddenly doesn't seem nearly as stupid anymore. It makes total sense, and they're like, cool, you know. So, all right, so let's review real quick. I'm going to go through this. We're going to look at eye anatomy. We're going to look at the muscles. We're going to look at the biomechanics of it and the nerves. And I think, let's see, who here is in Tri 4 or higher? Yeah. Anybody in Tri 3 or lower? You guys are awesome. I started myself. Hey, I got it. So we're gonna keep going with this. This is gonna be really helpful for you actually when you get to when you start coming along further in the program. All right. So we've got our eye muscles. The eye muscles. We've got the superior oblique muscle, the inferior oblique. You've got your rectus muscles, and those are just named just the way they are, superior and inferior, and then you got your lateral and your medial. And it really isn't any more complicated than that. Where it does get a little confusing sometimes, oh, I got a whiteboard over here, I'll use that in a second. Where it does get confusing sometimes is how these oblique muscles actually turn the eye. If you notice, this superior oblique muscle turns the eye like this. It pulls it like that, okay? Inferior oblique's just the opposite way. That's the only really, for me, the only really confusing muscle. The rest of them is it's just as it's labeled. Let me show you a quick video real quick so you can see in 3D just how these orchestrate that movement.
Hi, understanding the actions of the extraocular muscles can be frustratingly confusing, so I hope this video helps. You may also want to watch a video on eye movement terminology before this one. The eye sits within the bony orbit. The orbit has a roof, a floor, a medial wall and a lateral wall. It is therefore somewhat pyramid-like in shape. The two orbits have medial walls that run parallel to one another. The lateral walls are at about 45 degrees to the medial wall, or 90 degrees to one another. The eye sits within the middle of this space, with the four recti muscles converging on the orbital apex, where they insert into the annulus of Zinn, a fibrous ring of tissue that encircles the optic nerve. These recti are superior rectus, medial rectus, and inferior rectus, all supplied by the oculomotor or third cranial nerve, and lateral rectus, supplied by the abducens or sixth cranial nerve. The inferior oblique is also supplied by the oculomotor nerve, while the superior oblique is supplied by the trochlear or fourth cranial nerve.
We'll talk nerves in a minute.
Contraction of the lateral rectus abducts the eye, while contraction of the medial rectus adducts the eye. The two opposing muscles are described as being antagonists. Sherrington's law of reciprocal innervation states that when a muscle is stimulated, its antagonist is inhibited. This means that abduction is a combination of contraction of the lateral rectus and relaxation of the medial rectus. As well as having an antagonist muscle, there is also a yoke muscle which achieves the same movement in the other eye. So for right gaze or dextroversion, the lateral rectus abducts the right eye, while the medial rectus adducts the left eye. Herring's law states that yoke muscles receive equal and simultaneous innervation, the magnitude of which is determined by the fixing eye. When the eye is abducted 23 degrees, the superior and inferior recti are aligned with the axis of the eye. They therefore act purely to elevate and depress the abducted eye. The superior oblique acts to intort, and the inferior oblique acts to extort the abducted eye. When the eye is adducted, the inferior oblique and superior oblique become the main elevators and depressors. The superior rectus now primarily intorts, and inferior rectus primarily extorts. How can you remember these eye movements? Well, I draw a simple diagram. This diagram shows the abducted eye due to lateral rectus, with elevation from superior rectus and depression from inferior rectus. It also shows adduction from medial rectus, with elevation from inferior oblique and depression from superior oblique. Finally, for the intorsion and extorsion, simply turn the eyebrows into arrows. The superior rectus and superior oblique muscle are both intorters, which act in the direction of the arrow you have drawn. To criticise, comment or share your knowledge...
Alright, so I feel smarter just hearing that accent. Alright, so let's talk nerves now. Nerves are pretty straightforward, but this is what gives us a fantastic way to use these therapeutically, the eye movements, okay? So the nerves, great saying you're going to learn if you haven't learned it already, probably learned it with Giggleman in try 1, is SO4, LR6, all else 3, alright? And that simply means that your superior oblique is responsible when your eyes go in this direction. That is your fourth cranial nerve. Then you've got lateral rectus, and that's your sixth cranial nerve every time you move your eyes, this way. And then everything else is 3. We get to in a moment how we're going to use that therapeutically. All right, so now let's talk about eye movements. This is where we're really getting to what we do as functional neurologists and leveraging what the eyes can do to heal our patients' minds. First off, how we assess the brain using the eyes. Let's talk about the different types of eye movements. There's 4 types of them. And before I get to using the technical names, let's just think about what it is. The first type of movement is staring without moving. That's like lecture. That's you right now, all right? And so the first general type is you just stay in there, and it's like, there you go. That's our first type of eye movement. I'm not moving it anywhere. The second type of eye movement, I'll give you the name in a minute, darting, all right? It's like squirrel, all right? Except I shouldn't have moved my head. It's squirrel, squirrel. It's a darting motion, okay? It's like my dog, who's going to be better. All right. Third one is a following type of motion. That's like when you're sitting there and this, like a beautiful girl like my wife just walks by. You're sitting there, you're just like, you get your sunglasses on or you get your glasses on, and your eyes just kind of go, they just kind of move, right? But you don't move the head because you got to look cool, right? Like you're not really looking, like you're not really staring, but you are. All right, so that's the third type of movement. The fourth one is my head is moving, but I got to stay on target. So that's when you're doing some righteous head banging, but you're still watching the guitarist while they're doing it, right? So that's the other type. And this one's involuntary. I don't have to volitionally tell my eyes to stay on target. I just have to decide that I want to keep looking at Will back there while he's, eating some good old looking Doritos and those Cheetos right next to him. Look at that. And see, I can just do this. And all I have to do is decide I want to stay focused on you. Everything else is handled automatically, all right? So, how do we word that in neurological terms? Staring without moving, that's gaze fixation. All right, so I'm sitting here and I'm just looking straight ahead. I'm not moving at all. I'm fixating on my target, all right? Second one, that darting motion, that's a saccade. And this is where the terminology sometimes will throw you, so I want you to always think, saccade, squirrel. All right, that's when your eyes jump to something, okay? Third type of movement is when you're following it, you're pursuing it. I'm pursuing the girl, all right? It's that nice, smooth pursuit, all right? Fourth type of movement, nystagmus, all right? Nystagmus is, again, that's my involuntary one. These I decide to do completely. I'm in full control of those. This right here, that's something that my brain is doing automatically. That's nystagmus. We're going to talk a little bit more about that in a minute, but that's my eye staying on target, okay? Or trying to stay on target. Is that a better way to put it? All right. So let's talk about gaze fixation. First off, what is gaze fixation? And this is where you'll also note this is on the handout that I gave you. Gaze fixation is really important, and I didn't realize how important it was, honestly, until I started over the past couple of weeks, actually over Cerebrum, when I realized just how significant it is. Now, gaze fixation is the ability to hold the eye steady without moving off target. We've already established that. Fixation is the most basic eye movement skill from which all other skills are going to grow. Good fixation skills allow us to maintain a steady gaze without our eyes moving involitionally off target. This allows images entering into the eye to be centered on the fovea, the part of the retina that gives us clearest vision. When you can't fixate, images are going to be blurry and confusing. If you're in school, comprehension suffers because your eyes are always moving off the print and the words are jumbling and juggling around. Now here's what I've actually found, now, and I put down here in a moment here that difficulty with gaze fixation exhausts the patient. Here's what's happening, and you're going to see it in a moment, but when you have difficulty gaze fixating, I'm trying to watch something, and a lot of times I'm not even aware of it, but I'm sitting there, I'm like trying to stare at that ball right there, and my eyes are actually slightly moving. They're almost like tremoring, okay? And so every time they begin to lose, every time they begin to move off target, my brain corrects it, has to bring them back. And so my brain's doing this over and over and over again when I have difficulty gaze fixating. Mentally, remember, your brain uses more energy than anything else. How exhausting do you think that is? And I'm not even aware it's happening. So we'll have patients come in, and you'll see patients like this all the time. Let's say they've had a concussion, they've hit their head, all right? They're presenting with post-traumatic stress, or they're coming back from some sort of, they've had some sort of violence or crisis happen in their life. They've been physically assaulted, or victim of a crime, or who knows what, physically abused. Whatever, something's going on, and for some reason, and they say, you know what, all I know is that ever since I had that car accident a month ago, I'm tired all the time. One reason they could be tired all the time is they're having difficulty fixating. Okay? So how does this look? Because it exhausts the brain, because constantly correcting itself. Let's look at video here. This is how subtle that gaze fixation is, and this is where I actually came to appreciate sometimes the value of actually having machines that measure this for you. You see that slight, ever so slight jerk? Square wave jerk? That's someone who's having difficulty with gaze fixation. So as you're staring into your patient's eyes, and we'll go through this in a moment, how to do this, if you see that ever so slight, and you can really see it if you focus upon the cross right here, the crosshairs. See that? Okay, I got another one here for you. I have no idea what a Cognitator's law is. They made those.
Try not to blink at all.
See how their brain is constantly having to try and keep itself. Oh, what they're trying to do right now is gaze fixate, I think. Yeah, is that nystagmus?
Oh, stay there. Keep your eye wide open. Keep your eye wide open.
There you go.
Go look over to your right.
Actually, this is a different video. I put the wrong video there, but let's break this one down.
Back to center.
So what's that?
Left for every 2 seconds. Back to center.
It's 3rd degree, it's an all plane.
Well, it'll blow your mind when you're working with patients. Is right now you look at this and you're like, how could I possibly notice that? Well, this is pretty obvious. But you go, how could I possibly notice that? But the reality is one thing I've learned actually in the clinic is once you see it a couple times, it's really not hard to catch. You just got to know you just have to it has to come in your awareness of what it looks like. And so when you're looking at your patient, and the key also when you're doing this is you don't look straight into their eyes. You look at their nose. Because your peripheral vision is what's going to catch that. Jason, I think, was the first person to tell me that. You look at the nose. And it's true. So you just look at their nose, and once you've actually seen it a couple times, you're going to be like, yep, there it is. And you'll notice it. And you don't necessarily have to break it down for everything that it's worth. You just need to be able to categorize it.
Hey Matt, can I add something really
Please
quick?
do.
Okay, so terminology for this, when you look at gaze fixation, the act of gaze fixation could have an error, right? So if you're trying to gaze fixate, there should be eye on target with no movement. So the fact that we call it an aberrant movement or a wrong movement, the fact that they're trying to stay on gaze and they're trying to fixate on gaze, thing about gaze movement is there's no movement, it's actually locked on target. And then he mentioned nystagmus, which is if you come off of target. Nystagmus is like if you're watching train cars go by, to where you're pursuing the girl and then you find a new girl, and then you start pursuing that girl, and then you pursue onto that. So you gaze fixate a moving target, and then you find a new target to gaze fixate on. And then he also mentioned square wave jerk is when you're looking on, you're gaze fixating with no movement, and then all of a sudden your eyes jump off and jump back on.
Yes. Yeah.
So he mentioned all those things. So just for terminology, write them down if you guys don't know them. And then I think it's awesome. Look up like videos on YouTube that show examples, because if you guys can't see this in the patient, you're not going to be able to fix it because you didn't even recognize that it was there.
And honestly, you just need to see it a few times before suddenly it's like, oh, there it is. I was surprised, and it was Bryce that told me that. He goes, Matt, just, because I wasn't seeing it at first, he goes, Matt, you just need to see it a few times. And I was like, there it is. You know, and he was absolutely right. Once I saw it, so get on YouTube and just find this stuff and just take a look at it. And, or as I'm doing now, I'm beginning to work with other students, trying to help them out and doing neuro exams on them. And I'm like, whew, there it is. You know, I mean, once you see it, it's like, so I was like, Chris, we're working with someone that's got convergence problems. Now, would you see convergence in almost any patient now? Once you know exactly what it looks like. You know, once you see it, it's not so hard to find. And square wave jerks, I've been astonished at how many patients have that problem at Carrick. Oh, there we go. That's a dog party tonight. What's there?
You want to know what Alexander's law is?
Please do. I was wondering.
Well, Alexander's law is a unilateral vestibular loss, which produces nystagmus in both eyes, which is what we're seeing here.
Wow. Okay, so I have a lesion in one of my vestibular canals on one side, and it causes that lesion right there. Oh, there
Which
you go.
is nystagmus, yeah.
And that causes nystagmus. It's not causing nystagmus because I've got a canal that's being activated that shouldn't be activated, right?
And what they checked was all different positions. So sometimes you'll only see nystagmus midline, and it didn't matter where their eyes went, their vestibular system, because
Was
one was
still
broken,
confused.
said it was turning. Yeah.
Gotcha. So I didn't realize that. So, okay, we'll get to nystagmus in a minute. We'll talk about that.
Hey, as far as gaze fixation, though, this is something important. Everything you're saying, it's important to kind of check this in different areas, because you can have,
Pause for
kind of
2
what
seconds.
Jason's saying is, you can have a problem gaze fixating just in one visual field. So looking straight ahead, you might be decent, but then the same, everything you've said,
That's true. Yeah.
anything going on up in that area, or
Yeah.
if you had your head in a certain position, then you're going to be.
I forgot about that. That's true. That's true. And what's important is the first thing you're in a therapy with your patient is this. Because everything else you do with the eyes depends upon them being able to focus and stay on that, and it not being an exhausting and impossible task. So you check that gaze fixation in every plane to make certain they can accomplish it, and if they can't, guess what you do your first day or two of therapy with them? One of the things you do with them is you have them then stare in that plane. And you might move their head I'm still kind of new with this. I believe you move their head maybe in a no-no type movement. I think we can talk about that probably in advanced club more, but but the idea is I've got to get your eyes steady. It's the first thing I'm gonna do before I do anything else out of all this. Okay? So that would be your first day of treatment or your first take-home exercise that you send them home with. Okay?
So, Tally, when you're doing just practically, when they're teaching all the neuro exam, the things that they teach us in school, let's say you're doing pursuits with somebody, and you're seeing what you think is a saccadic intrusion or something going on in their pursuits, but it's happening in the same spot every time, and sometimes it'll be going this way or that way, and you're thinking, oh, they must have a right parietal, or you'll get there.
Right, we'll get there.
But don't forget to think maybe they just can't fixate on your thumb in that area.
That's money.
So always take a step back and say, make sure they can fixate on it there first before you start saying it's a pursuit problem.
And it would just be a matter of it happens at every spot, every time, right? Same thing?
Or is it one direction all the way across?
All the time.
Or, you know what I mean?
Yep. All right, so saccades is that sudden jump. And saccades, that's our ability to make a sudden jump. And with saccades, this is very important because I need to be able to suddenly change what I'm looking at and be able then to hold it. So let's say, I'm looking at Jason, and then all of a sudden someone tries to catch my attention up here. Tracy goes, hey, Matt. Okay, let's say I just can't move my head. I go, I need to be able to immediately look over there and hold it there. And so the saccade is measuring that, and there's quite a few parts of the brain that we'll talk about a little bit later that are actually involved with that, with that motion. But I want you to get a feel for the terminology. Now, so with saccades, we have figured out something kind of clever to do with saccades. Right now, like I said, we're just talking about the movements. We're going to talk about what it means neurologically in a little bit. But the movements, an anti-saccade is actually a way, and this is a little more advanced, but it's a way to actually see if you can resist a saccade command that's verbally given to you. So for example, if I were to say, I want you to now saccade to my right, I want you to resist that command and instead look to my left. And believe it or not, that gives you a beautiful window, and it'll make more sense as we get further along. That gives you a beautiful window into your ability to resist impulses, to resist compulsion. This is where it really connects. Hello, Alexis. I know we've got a lot of people here that are thinking more and more about how this connects with psychology as well, obsessive compulsive disorder, anything, impulsive behaviors. All the different, how many psychological issues do we have difficulty with either compulsion, addiction, or being too impulsive? And that comes, a lot of that can be contributed to by the fact that that's something called your basal ganglia. It's a more complex concept that we're not going to necessarily get into tonight. But the ability to be able to gate that, stop that. And you can test that with something called anti-saccades. Okay, so I'm going to throw that out there. We'll keep going and we'll talk about it some more. Now, where saccades get interesting, this darting, the squirrel, where this gets interesting is in describing how they can go wrong. And really, the way saccades can go wrong, it's called dysmetria as a general term. And you're going to hear, whenever you go to hear a speaker or Dr. Hall or somebody speak, you might hear them go dysmetria. You go, well, what's dysmetria? Well, dysmetria is simply an abnormal eye movement when you're doing a saccade. And so if a person has dysmetria, they'll constantly produce abnormal eye movements. And it could be, they could call them microsaccades, saccades, it could be some sort of flutter, square wave jerk. It's something's not moving right. And there's two different types of that. There's hypo and hyper, which is exactly how it sounds. You'll also hear terms, you'll hear all these words, you'll think they're talking about different things, and it's all the same thing. It's dysmetria, it's hypometria, or it's undershooting my target. So for example, once again, I'm trying to look at Jason, and let's just say Alexis goes, Matt! And instead, I try to go to Alexis, but I stop at Tracy. I undershot. That's also called hypometria, and that's a form of dysmetria. You getting all the crazy terminology, talking about just the same thing, right? Or it could be overshooting, and it's Tracy that goes, Matt! And I go to Alexis instead. So that's overshooting. Hypermetria, a form of dysmetria, and it has to do with saccades. All right, so can you add to that?
So how are we going to see this in an exam?
It's coming, it's coming. How does this look? Wah!
بسرعة. اوكي طالع اليمين بسرعة. يسار مرة ثانية بسرعة. اوكي شوف سيدة. شوف يسار بسرعة. شوف يمين بسرعة.
Watch this side.
يسار بسرعة. شوف يمين بسرعة. شوف سيدة. طالع فوق. شوف تحت. شوف سيدة بسرعة. شوف فوق بسرعة. طالع سيدة بسرعة. شوف يسار بسرعة. شوف يمين بسرعة. شوف سيدة.
Okay, now what's happening here, when he looks to the left, it's this eye. Okay? When he looks to the left, if you notice, this eye is hyper. It's going too far compared to the other eye. When he comes back this way, it's hypo. It's not going far enough. All right? So let me watch that again and see if you can see it this time. Again, look at the nose.
بسرعة. اوكي طالع اليمين بسرعة. يسار مرة ثانية بسرعة.
See it?
اوكي شوف سيدة.
Not like when I hear it say try to, not in his head.
يسار بسرعة.
Oh,
شوف يمين بسرعة.
you see it
يسار
now?
بسرعة. شوف يمين بسرعة.
Now it's plain as day. You're starting to see it now, aren't you?
طالع فوق. شوف تحت. شوف سيدة بسرعة. شوف فوق بسرعة. طالع سيدة بسرعة. شوف يسار بسرعة. شوف يمين بسرعة. شوف سيدة.
All right. Doesn't it? I tell you, right, you can. Jason gave me that one. All right, so look at that nose. All right, so now pursuits. Pursuits is really easy. Pursuits is your ability of the eyes to simply follow a moving target, nice and smooth. I'm pursuing the girl. All right, I'm pursuing her with my eyes. All right, and she's my wife, and I love her very much. So, been married 15 years. God bless her. And she, boy, she's a saint. And so you move back and forth. She has my dog at an ER right now. Man, pursuing her with my eyes. All right. So, how does it look when? And they need to be smooth, and they need to be evenly yoked. All right. So, how does it look when these fail? Again, we're just talking movements right now. See how they're jumping? They're not smooth. So now you know what a smooth pursuit should look like. That's what an abnormal pursuit looks like. So we got 3 of our categories covered now. We talked gaze fixation, saccades, pursuits. 3 different categories of eye movements we're looking for. As you can see, the pursuit's getting faster and faster and it becomes more pronounced. Oftentimes when you do tests with patients, you'll do it at different speeds. And the faster you get, the more it'll elicit a response.
You know, it's interesting, Matt.
Yeah.
Certain patients, especially like ones with ADHD and ones who are revved up, you might actually see the opposite. Sometimes
Really?
they're so used to, and naturally they are looking around fast, that slowing it down to a slow pursuit will
Yeah.
really bring out the problems.
There you go. There you go. All right. So last but not least, the 4th category is nystagmus, the head banging. All right. And nystagmus is an involuntary movement of the eyes that occurs when those semicircular canals are being stimulated when the head is not actually in motion. All right. So I always thought that was the easiest way for me to keep it straight. So whenever I see this nystagmus occur, I know that there's something going on in my brain, or let's say I've had a lot to drink and it's activated my cerebellum in a certain way that it's also messing around with my vestibular canals. And then when the officer pulls me over and does some sort of test with me, my eyes are jumping around a little bit and it's out of my control. Otherwise I wouldn't do it and get arrested. All right? So think nystagmus, think police, think head banging, think all that good fun stuff. Let's see what it looks like. And I think this is actually a video that police use to train. So it's kind of cool. The top is normal and the bottom is abnormal. That's nystagmus. Boom, 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 boom. And that's happening actually because of one or both of the vestibular canals being activated. Okay, and so that's, I don't want to get too much into nystagmus with this session. I think that might be better talked about when we get to the vestibular system. But I want you to be aware that that is a type of eye movement. Oh, we got another one? Oh.
As far as I know, Matt, it doesn't necessarily have to be vestibular, but it's called an in-range nystagmus. So if your eyes are drawn out that far, there could be a weakness in the eye muscles, and there can be a weakness in cerebellar tone, to where, and that's fastigium, to where your eyes literally don't have the juice, either the neural capacity or the muscular capacity to hold it in range. So what happens is it starts to come back, and it gains a little bit of ATP from relaxing, and it jumps back, and it gains a little bit more, and that's what you see, that in range. And
So I suspect cerebellum then, with this thing like
well, let's look it up tonight. Make sure. But I'm pretty sure there could be it could be a vestigial thing too.
Okay.
Yeah.
Okay.
So Matt, I
Yeah.
have a question.
Yep.
I hear sometimes people say like, this is a left beat nystagmus or right beat nystagmus. Like, what does that mean? How do you name a nystagmus?
I believe it's in the direction of correction. So it's not in the direction of the canal that's the problem. It's actually, we're naming it for the direction that the eye's correcting to. It's
The fast phase.
the fast. There you go.
You can think about it in the name. It's a right beat nystagmus. So it means it's drifting left and it's beating back to the right.
I like it. There you
Or
go.
vice versa.
There you go. So that's how you keep them straight, especially with Mars Band and his exams. Hello, Triforce. All right, you know, that's how you know what the direction of the nystagmus is always in the direction of correction, because you're correcting for that your eyes are correcting for what your vestibular canal is telling it to do. Vestibular canal is saying drift this way. Eyes go come back, come back. Okay. All right, so once again, these are our 4 different categories. Now we know what they look like. What we're going to be looking for as we now break down the neurology and the exam itself. I've got gaze fixation, I've got a saccade, I've got a pursuit, and I've got nystagmus that I'm looking for. So let's put it all together. We got our big picture here. Let's go back to what we're looking at doing. Let's talk about dementia. All right, my dementia, I'm going to once again start with my patient history or presentation. So let's see what that might look like. Okay. You've been adjusting Sally for years. She tells you that she has been forgetting things lately and is becoming confused. Her MD is telling her that dementia may be setting in and it may be time for assisted living. She longs to live independently with her grandkids until her grandkids go away to college, which is about another 2 more years. All right, so this is a good real life. Absolutely, you can see this. If not in your clinic, which I hope you would be, getting to know your patients well enough where you're adjusting them and you're doing their wellness care for years and years. And she begins to tell you, Dr. Jeff, I'm just getting kind of worried, and you're like, why? I may not be able to see you anymore because I may have to go live in assisted living, and my other doctor is saying that maybe I'm getting some dementia. And so based upon the history alone right now, and I hear you get this change in one of your patient's presentation, you begin to suspect what? You begin to suspect frontal lobe demise of some sort. Of course, there's probably more going on there, and remember Alzheimer's, for example, is a type of dementia. But you're suspecting, though, that their frontal lobes, which we talked about earlier, frontal lobes are responsible for that consciousness, that decision-making, that executive function. I'm not getting confused. I'm able to recall things well. There's some temporal lobe involvement there, of course, we talked about memory. But just thinking clinically, there we go. So there we go. I've got my change in my patient history. So now I'm going to go, you know what? Sweetheart, Sally, we're going to do a neuro exam on you. I'm going to do something with eye movements. I want to see how healthy your frontal lobes are right now. Okay? And Sally's like, what? We're going to use your eyes. Why are you looking at my eyes for, doctor? Because they're part of your brain. Brain tissue. Oh, that's cool. All right, so anyway. This is what I can do now to assess her frontal lobe. And we're going to start talking about the different types of eye movements. So let me get a volunteer. Jason, you want to come on up?
Yeah.
Just have a seat. I guess you just have a seat right here. Because I just want to demonstrate for them how it looks to do these kinds of exams. All right, so I know there's 3 different types of exams that will reveal to me that I've got a frontal lobe issue with eye movements. The first one is a horizontal saccade. And so I'm going to say Sally. Hey, Sally. I'm going to say Sally. I should have got the girl. So what I'm going to do is I'm simply going to hold my thumbs up like this in front of my patient. And I'm going to say, Sally, I want you to, this is Jason, if you would, I just want you to move your eyes towards my thumb when I click it, okay? When I flick it. Good. Now come back to center. Good. Come back to center. There we go. Come back to center. And so what I'm doing with her, and that's exactly what you just saw right there, I'm simply going in a oh, sorry, him. It's all right, Caitlin. So what we're doing is going back and forth in the horizontal plane. And that horizontal plane particularly is frontal lobe. What's interesting is it's my contralateral frontal lobe that's starting the saccade. It's my ipsilateral cerebellum that stops it, which I think is where we're getting to a little bit with, anyway, I'll confuse myself if I'm not careful. So here's what happens, and I'm looking at this, and I'm going, okay, I'm noticing that his left eye is having difficulty with this saccade as we're going through this. And that tells me, okay, I'm suspicious then, as it could be his right frontal lobe, that's my problem, or perhaps if it's having difficulty stopping at my target, or if it's overshooting, we'll get to that in a moment too, it could be the ipsilateral cerebellum, which would be that left, same side as the eye that's having the difficulty. Okay? So now I'm beginning to isolate and see if Sally is having difficulty with her frontal lobes. Okay? I also have downward saccades, which involves frontal lobe as well as a little superior colliculus mapping, which if you guys could explain the superior colliculus part, that would help me. I understand superior colliculus is vision and whatnot, but this was something Dr. Shores, God bless him, told me with this. Does anybody know the superior colliculus connection?
So
Yeah.
let's talk about both of those really quick.
Sure.
Because this is how it affects chiropractors and posturing too. So if a patient comes in, especially chiropractic patients, and you want to catch Parkinson's or something early, if you're looking at Parkinson's or Alzheimer's or supranuclear palsy or any of these things where you have frontal lobe demise, which way do you think is going to be really hard for them, or let's put it this way, which eye movement, up or down, is going to be harder for them 20, 30 years out before Parkinson's? I'm going to ask the same question in a different way. If you have frontal lobe demise, which way do you perceive sway? Do you perceive yourself more back or more forward? You actually, in all cases of frontal lobe demise, you perceive yourself back, so you compensate by doing this.
Which is why elderly end up doing this.
So where do your eyes go?
Oh.
Your eyes get plastic up. So what's harder for you to do, up or down? Since they're always up, it's harder to go down. So when you do a check and all of a sudden they can't look down, you're like, oh crap.
Downward saccade.
So
There it is.
there's that. And then in terms of superior colliculus mapping, it's the same thing, but you've got parietal feeding in. Where is the superior colliculus, first of all? Top of the brainstem, so yeah, midbrain, mesencephalon. So always check that because all of those things are gonna feed into the frontal lobe. So if you got frontal lobe demise, you gotta figure out, is it a dopaminergic projecting system? Is it because they've got parietal, temporal projections forward to the frontal lobe, prefrontal? But based on that, you've got a really, really good idea about what's feeding to the frontal lobe, because you've got midbrain projections, all the dopaminergic activating systems, up to the ventral, whatever, midbrain.
Yeah.
And you've got all the sensory stuff.
So when we talk about like parietal mapping, we're talking about a map of your body, right? Whenever you talk about like superior colliculus or inferior colliculus mapping, that's an external map of the world around you. So like
That's it.
another
Thank you.
reason why
Boom.
that's one reason
About
why
the short set.
Jason says look at their nose if you're watching their eyes, because your fovea, which is focused on their nose, that's the purpose of your fovea is to pick up fine detail, whereas the purpose of your colliculi, your collicular mapping, is to pick up on movement, to pick up on stimuli, so that you will saccade over to it,
Right.
pick up on that squirrel.
Right.
So that's why you don't actually want to look at if you're looking for motion, you don't. It's better to look at it in
Let
your
your superior colliculus do it for you.
Exactly.
By not looking directly at it. Okay, so, and so keep in mind, as we're talking about this, remember, that's the idea of doing the full neuro exam. So you find these kinds of things and you're like, oh, wait a minute, could there be involvement of the parietal lobe? Could there be involvement of the temporal? And that's the beauty of doing the full neurological exam, because what's going to happen, as you've seen us do in clubs sometimes, is you're going to keep getting positive findings for certain spots. And that way you're not just going on one finding, all right? And so this is one, these are some of the tests you can do for frontal lobe, and there's other ones too. We'll get to those as well. Also, there's a list, by the way, on the back, if you want to be able to have something to reference, because I know this is hard to all keep straight, and I'm like, somebody likes to have things in front of me. So there you go if you want to be able to refer to that. Antisaccades, this is just I just want to show you how it's done. Might talk about it later when we do a lesson on basal ganglia. But how it's done is you simply say this and say, okay, all right, when I shift my thumb on the right, whenever I do this, I actually want you to choose to look to the left. All right? Yeah, right. All right, so, and you'll see Jason looks over here. And then, all right, come back to neutral. There you go. Come back to neutral. And I'll watch Jason do this, and it's a great way to see if he can resist that impulse to do that. So we won't talk too much about that just yet.
So I got a question.
Yeah, please.
If you're looking at like basal ganglionic or frontal lobe stuff,
Yeah.
okay, and you're having someone do antisaccades, in addition to just like hyperemetria or hypometria, what are you really looking for? Like what you'll see is when you say,
It's a
so
goat.
if I wiggle this thumb, I want you to look at the one that doesn't move. But if someone has a basal ganglionic issue, a lot
Will they
of times what
begin to
you'll
look?
see is when they get that stimulus,
Yeah.
they'll look at it and then jump over to the eye that they're supposed to be looking
Ah,
at. So
okay.
they can't
Okay.
inhibit that stimulus of motion.
Gotcha. Also, they're seeing the motion, superior colliculus and all that saying, look!
You talked about antisaccades to show frontal lobe inhibition.
Yeah,
It's inhibiting the fact that I want to look at that moving thumb.
right.
So
Self-control.
if I'm keep
OCD.
jumping at it,
There you go.
start thinking frontal lobe.
Lots of psychology connections there. All right. All right. Yeah, those are coming. That's the frontier. That's the new frontier, baby. I'm right there with you. That's what lights my fire. All right. So, for all saccades, I want you to watch for the inability to gaze fixate. All right. If I see a difficulty in gaze fixation, in other words, if you can't go to the target and stay on it, all right, with this saccade, remember, Jenny, then that could be a cerebellar or brainstem, some sort of brainstem lesion that needs to be stabilized before you move on. Also remember, a difficulty in gaze fixation can be medicinally induced. So never forget to rule that out as well. Okay. Hypometria, it could be because my frontal lobe, which remember, your frontal lobe is what is the gas, the cerebellum is the brake when it comes to saccades. So while I'm performing this, if I see it undershooting, hypometria, a form of dysmetria, then that could be that my frontal lobe's too weak, or it could be my cerebellum's firing too strongly. All right? Hypermetria, just the opposite. My gas is too strong, my brake is too weak. It's going too far, it's overshooting. Okay?
And a really cool trick for hypometria, if you've got hypometria on one side, let's say I'm over here, and I'm hypometric to the right, and let's say it stops here and then it goes here. A cool thing I can do is called a Helmegi, and it's when you do a rehab, you say, okay, look on 3, 1, 2, and you jump there, you move their head the opposite way. So you incorporate their vestibular system, their left vestibular system, which is going to kick their eyes right, and it's to add juice to the parietal lobe and that cranial nerve to kick it to the other side, right? So if the eyes by itself aren't enough, you can do that, and it speeds it up
And
it
help them
drives
do it.
more. And you can do that a couple times, and then get them to do it without a head thrust or a Helmegi, and then it's normal. And that kind of drives that system a little bit better too. It's like a really quick fix.
Let's say that again. So it's hypometric. I need to try and get the eye to move further.
Yeah.
To stop undershooting my target.
Yeah.
So I'm going to help that by happening by literally the Helmagi, but I'm going to move your head in a way that helps you with that eye movement.
Yeah, so if I'm looking at this dot right
To
here,
strengthen it.
if I move my head left, the vestibular system tells my eyes to go right? So same exact thing over here, where if my eyes need to go more right, I use that left vestibular system.
I just come over here and I'm like, oh, we're going to help you out.
I would do it from the front so you can see it. So,
Right. But yeah, that's what you're saying. But go ahead and help the patient in the process.
so do it to me really quick. just
Okay.
So they can see it.
All right.
So you give me, well, for you, it would be a dot, right? So
Okay.
I'll do this and you move my head.
All right.
So,
So I'm going to tell you, I'm going to say, okay, I want you to look, I want you to go ahead and look to your right.
okay,
All right. And
and I'm on your nose.
and you're on my nose. All right, on the count of 3. 1, 2, 3.
Perfect.
There you go. 1, 2, 3. And you see, what I'm doing is I'm helping him. We need to face them so they can see what's.
Y'all tell me,
Do
y'all
y'all,
got it?
did y'all follow that? Okay, I'm helping him do it. And that's something we're going to get to when we get to actually how to use these. Here's the beautiful thing of functional neurology. The test becomes the therapy. The test becomes the therapy. All right? You learn to do the neurological exam, and then you use the neurological exam to exercise the weak thing that you found. So if he's weak and going over here, I'll say, well, guess what? We're going to do that 10 times. And I'm going to help you by moving your head. I didn't change anything. The test became the exercise. It became the therapy. That's the sweet simplicity of this. All right? Now, and then hopefully I have some other things that I can do on top of that. All right.
Can I add one little thing? to
Please
that?
do.
So, of course, there's tons of variables, and we can touch on a little bit on this in Advanced Club, but like, for example, something just like that exercise right there,
Mhm.
probably the best way to do that is to keep it as quick as possible, so as much acceleration, but as small of an amplitude as you can as well. Because if I turn his head over here, now I'm having to saccade, instead of this much, now I'm having to saccade this much. But if you keep it quick to really activate that vestibular input,
Mhm.
but it's just a small
That's good to know.
amplitude,
Okay.
you know what I'm saying? You can change and play with these variables to really make what you're doing super effective.
And it makes sense if this is a 1-to-1 ratio. If I move 20 degrees in my head, my eyes go 20 degrees to the right. Right? 20 degrees left of my head, 20 degrees right to my eyes. Stay on the same target, straight ahead. So if I undershoot by 20 degrees, just go 20 degrees with your head.
Only move the head however much they're undershooting. That's brilliant. I love that. Just move the head however much they're undershooting. Cool. I wasn't going to review this, but I think we already got a feel for how they look with saccades. So let's move on to the next one.
All right, you can do that here.
Go ahead, stay. We'll do some more. Just so you know, so what I would do is, okay, after doing this with Sally or Jason, okay, and I'm like, oh wow, okay, well let's go back to Sally. Okay, Miss Sally, oh my, okay, I'm seeing, okay, I'm thinking to myself, I don't tell her this. I'm thinking to myself, ooh, got some positive findings there. I did the horizontal saccades, I did the downward saccade, all right, and I'm seeing some positive findings there, so I go, okay, you know what, I'm going to confirm this. Now this is, it'd be nice if I did the full neuro exam, but let's just say I got 3 more patients waiting, and I just wanted to see what we can get for today, and then we'll come make another appointment. So I could do, some other tests I can do what's called a Pencer's test, and I assume we'll cover these later, but I just want to give you an idea where you have them hold up like this, and you go, okay, and do this as fast as you can, do this as fast as you can, and that's a way of measuring frontal lobe as well. I can do foot tapping, and this is always contralateral, okay? I can do a pull test, which is really kind of cool, but you gotta be careful doing it with vets, all right? Or anybody for that matter, where they stand up, or you wanna do a pull test on me?
Yeah.
Here we go.
It's just a perturb test.
I think so. Well, actually, I think when I saw Shores do this, I want to say he's like, okay, I'm going to pull you real hard, all right, and just so you know, and I want you to go ahead and catch yourself.
What do you mean?
There you go. It should only be 1 or at most 2 steps. If it's more than 1 or 2 steps, that's actually suggestive of, it may give you a lot of things, but it is also an indicator of frontal lobe.
What's
That
it
it's
called?
slow.
What's it called if they go like this? I do it again?
Yeah. Here's how it would look if it's bad. which, like, for example, Layla. You'll see Layla have trouble. I'm sorry, I guess I shouldn't call her out. I know. She's big.
That's okay, I know where she is.
All right.
I've
So
said
what's it
too,
called?
so, sorry.
She has a big exam tomorrow. I know she
No,
does.
I know where she is.
So that's festinating.
Festinating.
So that's like frontal, midbrain, early Parkinson, stuff like that.
There you go. Right? And then also then the perturbation test. You want to do that one on me?
Yeah.
All right, perturb me.
Okay. So obviously, before he closes his eyes, I want to make sure that he's not going to tank, because there's somebody in try 3 that if you close her eyes, she would literally be thrown to the left. So his eyes are closed. He's okay, right?
Yep.
So Matt.
Feet together.
Oh, that's right. That's right. Feet
And
together.
that just makes the base of support less, so it's going to draw his head a little bit more. Okay.
Oh, see, there it is.
Okay.
So that was contralateral. So which side of which lobe was that was weak? Yeah, it fell to the right. Honestly, I'm not sure.
If he fell to the right, so this to me is a really good cerebellar test, because if I hit him this way, and he doesn't have the muscle tone over here to draw himself back over, it's a left cerebellar thing.
There you go. Which is my axis, my axis of therapy. Left.
So, and then do this too. So close your eyes. And then his initial sway was left. So if you got a really strong base of support on these paraspinals and a really weak over here, guess which way he's going to timber to, right? If you're holding yourself up with 2 sticks and one's a really crappy stick, guess which way you're going to go. That makes sense. So not only did, just by standing there, he leaned this way, but when we pushed him, he didn't have anything to bring him back. So that makes sense.
So I'm weak over here.
You know what's
That's
really
cerebellar
cool
weakness.
is like a lot of this neuro stuff. There's multiple ways you can explain it, but in reality, it's all happening. I'm sorry, I got done.
Enjoy that people donut.
There's some crispy trees.
Can we crash zoom Mike on Bryce with his donut? See if you can zoom in inside his mouth.
Open your mouth. It's in there.
This is going on fine. But okay, what I'm trying to get at is I explain that a little bit differently. I explain it by proprioceptive input. You have to have an input to reflexively correct yourself. So if I am not receiving good input from my right side and someone hits me on the right side, it's going to take me a little bit longer to realize I'm falling so I can correct it.
That's true.
But the point is, you should be able to explain this stuff multiple different ways. And the thing is, it should all match up.
Right. Because you're gonna do multiple tests.
Same things with like the chiropractic exam.
It should all come back to the
analysis.
same issues. All
Unless
right.
they have multiple lesions, and then you're going to have distractors.
Right.
We're in club, we're trying to make it as pretty as possible by drawing out one lesion. But people come in, they're going to be 40, 50 years deep in life's crap, right? So who knows? They could
It's-
be.
I've shadowed with docs and I love it. We'll get through seeing a patient. I'm sitting here. I've done breaking down the neuro exam and I can do all that. And I'm sitting there and I'm all through the neuro exam. I'm like, yep, there's a lesion. Yeah, it's left frontal lobe. No, it's right frontal lobe. No, it's over the left now. Oh, it's parietal lobe. You know, and I'm all over the place. And we get done and we go back in, and before we give the patient a report of findings, doc goes, so what do you think? And I look at them and I say, honestly, I don't freaking know. I said, this patient's a mess. They go, exactly. I said, so what are you going to do? I don't know. What do you want to do? That's literally their response. They're so messed up in so many ways. Basically, we go, okay, well, what's worse? Let's just go ahead and calm that down so we can begin finally getting some better results, more clear results in our neuro exam. You know, so don't be surprised if that happens, and you hit what was worse. Let's calm it down. Does that make sense?
Sounds good.
Cool. All right. So that's go backwards. Wait, that's right. All right. So there we go. We identified our deficient parts of our brainstem. You know, and this is happening. We're pretending this is in your chiropractic clinic. All right. So now you go. I need to activate those regions, either in my clinic or I send them home with exercises. Okay. So let's just go ahead and look through this. We can really hit this more in advanced club. But what am I going to do? Well, with this situation, let's just assume that all that's going on is her frontal lobe, or there's just a lot of things that are demising. Now, this is what we're finding right now with Alzheimer's, for example. I was talking with Dr. Brock about this just last week, all right, or actually earlier this week. And I looked at him, I go, okay, you know, what is our primary goal with Alzheimer's right now? We're getting some really great results with this, and dementia, and this different lobe demise. I said, can we stop the demise itself? And he says, realistically, right now, no. We may be able to slow it down a little bit. But you know what's really happening here is we're saying as chiropractic neurologists, your frontal lobes may be demising right now, and you're beginning to lose your memories. You're losing your connection. You've seen that movie, The Notebook. Oh my goodness. You know, all that stuff's happening. what we can do is we can activate that like crazy, and what's left of the frontal lobe, yes, I am married. I get all the chick flicks.
Just lost your man card.
Hand that over.
I know, right? Where's that man card? I gotta turn it in. So, 24-hour suspension, man. Maybe 48. So the frontal lobes are demising, right? But guess what? I can cause neuroplasticity in what's left of the frontal lobes and make them more efficient and make them work better so that while they're demising over here, what's left is improving, and the net result is, whoa, my memory loss begins to stop. And my function begins to maybe even improve. And so they're even doing some studies right now where sometimes, they're having some Alzheimer's patients where they just adjust them a couple of times cervically, and give them cervical adjustments on a regular basis, and they're actually seeing that they're actually halting that kind of, that demise, well, they can't stop the frontal lobes from demising, but they're the functional demise. All right, and that's what's so exciting about us being able to use this in neuroplasticity to help our patients. So in my primary treatment, adjust the daylights out of Sally. So anybody that goes around saying, Neuro Club is against adjusting, no, not at all. I've got a student right now that I'm helping out that I'm doing lots of setups on to help who's got parts of his brain that are underperforming, and I light this guy up with some aggressive setups. All right, as much as I can, and it's incredible the results that come from that. All right, but so my goal was to use the adjustment both as a means to remove subluxation, but also as a modality to stimulate the brain. So I'm going to find every subluxation I can on the proper. Let's say it's her left frontal lobe that's demising, which probably it's both of them, but let's just say it's the left. So I'm going to go up and down the right. I'm going to find every subluxation I can find over here, and I'm going to adjust it. You know what? And honestly, I'm almost going to just go ahead and do thrusts anyway if I know it's not going to hurt her, just to get that stimulation up there. Light it up, light it up, light it up, all right? And then, that's right, make certain if it is just one side, you don't want to go and start hitting. I've got situations now where I try to help people, and then they go into lab and they get adjusted on the wrong side. And I'm just like, oh. Because especially if it's a frontal lobe thing, because let's say if I've got one of my frontal lobes that's really overperforming, all right, another one's underperforming, how does that oftentimes reveal itself? I become emotional. And so if I'm already having difficulty and I'm getting emotional already because, like, let's say Sally here, let's say it's just one side for her. All right, she's already losing all kinds of things in her life right now. She's afraid about not being able to stay in her home until her grandkids graduate from high school. She's already emotional, and then she goes to see a chiropractor, and he just decides to adjust every subluxation he can find, no matter which side of the body it's on. All right, so then what was a hemisphericity? One side overperforming from the other lobe just continues to exacerbate and gets worse and worse and worse. So what's happening is okay, maybe you're hoping the adjustment is lighting up the weak side, but it's also creating that difference to get worse and worse. She's becoming more and more emotional. She's not able to get her emotions, and you're making the situation worse than it needs to be. All right, so yeah.
You know the term limbic escape?
Oh.
You think about that. So what's it escaping? It's escaping the control of the frontal lobe.
Oh, I like that.
The frontal lobe is
That's
crashing,
money.
whether it's one side or both sides, for whatever reason. Then you'll start seeing that limbic escape. And
I can't stop
that
it.
emotion coming up.
There you go. I can't stop it. So that's why you get, yeah.
Good.
No, wait.
Dementia, we're also trying to figure out what's causing the dementia too. So not only you're seeing the dementia is causing a decreased firing in the frontal lobe, but Dr. Sam Yannick talks a lot about bracketing your therapy. If you're going to adjust them a lot, if you're going to do a bunch of neuro rehab on them a lot, he brackets it with either anti-inflammatory supplements before and after, or things to provide vasodilation or more oxygen, more blood flow to that area.
Nutrient balance,
So,
Apex.
Yeah, so all those things.
Tomorrow, yeah, brilliant. And keep in mind, yeah, right now I'm using this I'm using this as a framework to teach you eye movements, but you want to come at it metabolically as well, and all of the above. Keep it coming. All right,
Hey, Matt.
so
Matt,
yes.
I got a question real fast.
Please.
So that actually guy that you've been treating,
Yeah.
he actually came up to Mike and I earlier today, and we've just, obviously been doing right-sided adjustments on him.
Mm-hmm.
He said today in class I noticed that whenever I'd follow Dr. Russell to the left, not move my head, just try to follow him to the left, I would become like extremely exhausted, just tired, and I couldn't keep following him. And so it was complete exhaustion just trying to follow him to the left. So I'm just, we're talking about eye movements. I'm just
Oh.
See what y'all, what your thoughts are on that.
Let's work that. Sounds like I need to do an eye exam on
So left gaze fixation is what part of the brain? Just keeping your eyes right here with a head straight.
What's your left side of your brain too?
Well, I'm not even counting moving my eyes over there. I'm just saying if my eyes are over here, what's keeping them over here?
Your cerebellum.
Which one?
Your ipsilateral. No, your contralateral.
Yep, contralateral.
Oh!
Because it's associated with a right vestibular movement and it integrates on the right side. So it's right cerebellum, left gaze fixation, and it just sits, right?
Mm-hmm.
So even if it's all that is, if you try adjusting them on the right, and then you do the same exact thing, see if it gets better.
Yeah.
Because you want to provide input in that cerebellum, juice up that cerebellum.
Which
a little bit.
matches, and we know his right cerebellum's weak. So there you go.
Okay.
There you go. That's perfect.
Try that.
Love it.
Yeah.
If they're
I love it.
having a problem pursuing over there, then you know, and he's going to
Right.
explain.
We're gonna get to that, yeah.
Yeah, and then if it just looks over there, it's something else.
It's
So
like God.
Well, we've been adjusting him, and every time he has great energy for about 20 minutes, and then it'll crash. And
We
so,
think it's primarily metabolic,
cool.
which gets back to the nutrition and the importance of
Ties together. Man.
You got it. You got it. All right. So, great question. Okay. So then, what are some secondary therapies I can do to support that adjustment, that activation I'm doing? Some things that came to my mind that I would like to do, just using some of the resources I've got. You can actually take a TENS unit and put it on the cervicals where you are adjusting them to keep that stimulation coming in. I think that's a brilliant idea personally, and it's very affordable. You can do it in your chiro clinic. All right, so if you're like, man, I wish you had enough subluxations where I could adjust you all day long because I just want to activate that frontal lobe. Not you wishing subluxations on people, but you get what I'm saying. I wish I had an excuse to adjust you more because I want to activate your frontal lobe, And hey, wait a minute though, I just adjusted you. Let me put a TENS unit on right there. Turn it up. All right. Also, contralateral cerebellar activation. And that's like figure eights on the opposite one. Contralateral music. Oh, I wish our Try One buddy was here. We have a music therapist now that may be coming to the club. We're going to really recruit him. Yeah. Try One, no less. What was his name? Sean. All right, everybody, we got to stalk Sean. All right. I should have took off my mic there. All right, contralateral music, light stimulation in a contralateral visual field, which I think I would love if Bryce would talk about that on Monday.
We're going to talk about this on Monday for sure.
Ipsilateral smell, take essential oils, smell on that side. But this is all stuff they can go home and do. OPKs we'll talk about a little bit later. But just all kinds of just really cool things that you can do. That you can do this in your clinic, all right? So you have your chiropractic assistant. Then, after you've adjusted, go through and do these with Sally, all right? And then you send her home with some stuff. What can she go home with? Tell her to learn some new songs. Tell her to change the radio station and try to sing with every new song she now hears. Tell her it's time to start listening to country, all right? Or you know what, Miss Sally, R&B is where it's at. I want you to tune over. Tell her, that'd be really funny. I'm sorry, thinking about my own great grandmother. But tell her to start singing with that song. Learn new songs. Recall well-practiced material. So tell her to become part of a local play where she has a small role. Okay, join her church choir. Tell her to start reciting poetry. Play in her local orchestra if she plays an instrument, okay? Also, listening to complex concepts. Tell her to enroll in a course at her local community college where she's listening to lecture each day. But all of these things are really good at activating frontal lobe, all right? And so this is stuff that you tell her then to go home and do and keep track of it, and then you begin to see her, and you might be surprised just how long she can keep from having to go into assisted living. You know what? And you want to talk about making a forever change. That's what we do. All right, so we just went through all of it, and then the final stage, I'm going to recheck and modify. Miss Sally, since we're just now starting this, I want you to do this. I want you to see it a couple times this week. I want to see it 3 times a week for the next couple of weeks until we really begin to see some results here, and then we're going to start backing that off. But I'm going to do everything I can, Miss Sally, to not only make certain that you're subluxation free, that you're as healthy as you can be, but I really want to make sure your mind is as healthy as it can be, and I want you to be able to stay in that home. So that's how you do it. And if you're wondering what to charge, I think Dr. Stengel charges, I shouldn't say that on the mic, but I'll tell you guys later, some different fee schedules you can use, that sort of thing. All right, let's talk PTSD. Continue to put it all together. We're going to talk about how you can then assess eye movements, the mesencephalon and the pons. Patient history. Just remember, we already went over this, these different steps. Here's what you got on your hands. Janice has been getting regular chiropractic care for her pregnancy, while her husband Luke has been finishing his second tour of duty in Afghanistan. Very realistic scenario, right? Okay. Now home, Janice says that Luke is in a constant state of aggressive anger or controlled panic. All right, aggressive anger or controlled panic. What's that another word for in terms of what we do as as chiropractors? That's fight or flight. That's your sympathetic system. Okay? Always in that state. He's having violent night terrors, which is what you call it for people with PTSD. It's just nightmares that are just really shaky. And so he's not sleeping well. His memory is severely impaired. And so you go, you know what, Janice? You know what? Have him come in, because I've actually done. I was a part of this group in my chiropractic school where we learned how to work with PTSD patients, and it's pretty miraculous what we can do. So come on over, bring him in, Janice. Would you? I'd love just to. I won't even charge you for it. I just want to just take a quick look at him, and then we'll see what we can go from there. All right. So go back to what we've done. So now we got a change in. We got a change in presentation with our chiropractic patient. Okay. So we're going to try and get Luke to come in, and we're going to do a neurological exam on him. And with Luke, what we can do then is we're going to do a couple other eye movements. First one we're going to do is convergence. Now convergence, it looks just like that. It is what it sounds like. I'm going to get in front of my patient. I'm going to put my thumb right in front of him. I'm going to say, just keep your eyes focused upon my thumb, and I'm going to move in nice and slow. You're a little off, buddy. And I'm looking for. Well, actually, if you want to see, you want them to see? Yeah. Is that cool? All right, turn around this way. You guys, come around. I'm going to show you exactly what convergence being off looks like. What this means, this is a way of assessing my mesencephalon, because his eyes, what cranial nerve is responsible for coming in? 3, right? Cranial nerve 3. Real quick, just to remind you, cranial nerves, learn this from Mars Band. It's just, he doesn't teach it this way, and it's so easy to learn, remember it this way. All right? Your cranial nerves. All right? You got your brain here. Okay? And I've got my mesencephalon right here, my pons right here, all right, and then my medulla right here, okay? And my cranial nerves literally are 1 and 2, which is up in my cortex. Then I've got 3 and 4, 5, 6, 7, 8, 9, 10, 11, 12. That's how they're distributed. It's that simple, all right? Where literally 3 and 4 assesses my mesencephalon, that's my sympathetic response. 5, 6, 7, and 8 pons, that's parasympathetic. 9, 10, 11, and 12. And as chiropractic neurologists, this is how we bypass when a person can't handle an adjustment and having everything lit up, and I need a very specific way to target a part of your brain. Here's my window. That's what those nerves I'm going to use. All right. So when he converges, he's using 3. 3 is all mesencephalon. So if his mesencephalon's not working well, you'll hear that sound, and you won't see them evenly yoked, and there'll be some delay if there's some struggle there. So watch Jason's eyes. You see how they're not moving evenly? Look at his right eye. Slower.
My personal, this is like doctor preference, but to me, it's mesencephalic, and you're dealing with somebody's PTSD. If you bring them, the more and more unstable they get, this is probably good.
Okay.
If you bring them all the way in, they're going to go limbic on you. And you're not going to like it because they might attack you in your office, right? So the more and more unstable you get, I mean, this is more and more of a failure, and then more and more of a mesencephalic limbic escape they're probably going to have. So it's uncomfortable to the patient, it's uncomfortable limbically and for their eyes. So if you're following, you assess that it sucks, you know it sucks. And if you're going to do therapy out here anyways, you're not ever going to start in here. You're always going to start out here. So, if you're in here and they're still good, they're probably pretty good, because functionally we don't ever do anything this close to our face anyways. So that's personal preference. Some doctors might say other things different, but I mean, if you can get within 2 or 3 inches of their eyes, you're doing pretty good.
So, all right, you make your seats. So the opposite of this would be divergence. And divergence, I'm going to start and then I'm going to work out and watch his eyes diverge. So now I've got my lateral rectus, LR6. Exactly. So I got lateral, I got LR6, making my eyes go like this. Okay? And so that is all pons. That's parasympathetic. The exact opposite. Isn't that sweet? So now I'm assessing his pons. Why am I assessing both at this point with Luke, with my PTSD patient? Because there's two things that can be happening, and probably both are happening with PTSD, or any sort of difficulty to try and keep your sympathetics gated, which is what chiropractors are so good at, right? One thing that's happening is probably his mesencephalon up here is screaming loud. All right, that's your primal center. That's your sympathetic response. That's why he's always aggressive, and he's always in a controlled panic. Okay, at home, which means his marriage is falling apart and things are rough. Who wants to live with that, right? The vast majority of PTSD ends up in divorce. That, I mean, like 75 to 80%. Okay, so that's also something to have on your radar when you're treating people. And then his pons. The pons is responsible. Your PMRF, which is your pons in your medulla and reticular formation. It's responsible for stopping the sympathetics, which is what we call parasympathetics. But really, you're gating it. It's like the dam that's closing the waters. All right, it's keeping it under control. And so his pons is probably too weak, and his mesencephalon is too strong, and both are probably happening at the same time. So I'm looking at both of them. I'm assessing both of them when I do these different types of tests. All right. So we did divergence.
Ooh.
Yes, please.
All right, so let's say we're going to test for saccades or pursuits. You never, ever, 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 ever do them in convergence. Cool? So you always, the first test you do, even before you do this, to find where they are, is to bring them into convergence, just to the point where you see their eyes converge, and you take them out of that, and that's whatever distance you do in your pursuits.
Write that down.
If you have a patient who's super fragile, you can be doing these eye movements a few feet out to keep it nice and smooth.
Okay.
If you're trying to bring out the problems, you want to do it right out of convergence, because that's where it's going to be the most challenging for them, but you're still not
That's your starting point.
in convergence.
All right, y'all followed that? Go into get right outside of the zone when they begin to converge. All right. So now I'm going to do an upward saccade. Upward saccades are your mesencephalon and some superior colliculus mapping, because when I go up, it's all superior. It's all cranial nerve 3, and it's also still superior colliculus for the same idea. This looks just like this. I think you guys kind of know what it's going to look like. So you just come up to my thumb, boom, come back. There we go, up, and then back. There we go. And so I'm looking, same as before. I'm looking to see if there's any sort of see if there's what we'd already saw earlier, some sort of dismovement. If it lies short, it's probably frontal lobe. If it goes too far, it's probably cerebellum. Remember, that's my break, and that's my guess. Okay. And then vertical pursuits. These are interesting. You're going to see these a lot, especially if you're going to have a chiropractic clinic. You're going to see this like crazy, and it blows my mind why we don't assess it more. Vertical pursuits. What they do is whenever let's say someone is a whiplash patient. Whenever someone has whiplash, this happens almost every single time. If we go back to the slide where let me show you the anatomy, or let me show you how the brain and the. Go back.
Matt, I'm going to jump back here so I can read it.
Yeah, please. Good, dude. Yeah, of course, like on the top. Oh. Don't look at the screen. It might hurt. I thought I had pictures of the lobes here. Oh, sorry, thought I had pictures of the lobes there. All right. But what's happening whenever a patient has whiplash? Okay, they're in a car accident and they go. All right. Think about where within. If you look at the brain and you want to see where the foramen magnum, or where you got this massive brain, and then it's sitting right on top of what? Right here. That's my mesencephalon. Right? And whenever I get into a car accident, my head snaps. What's going to really get snapped in a strong way is my mesencephalon. All right? And what will almost always happen with whiplash patients is what you're going to find is that then their mesencephalon is going to get kind of scrambled because everything got bent. Everything kind of just all at once. All right? And so you're going to go through and you're going to perform a vertical pursuit. A vertical pursuit, when you go up, the muscles that are responsible for that are cranial nerve 3. When you go back down, then you got cranial nerve 4 kicking in, SO4, okay? And so when you start going up and down in a vertical pursuit like this with your patient, all right? And you tell them keep their head steady, and they go like this. They go down, then back up again, then back down. What they're having to do with their mesencephalon, they're having to switch back and forth between cranial nerve 3, cranial nerve 4, cranial nerve 3, cranial nerve 4. And so if things have gotten scrambled in here, and you've got you got some difficulty with that integration happening, they're going to have difficulty doing that smoothly. Which means you then need to go ahead and as part of their treatment for all the other things that they've come to you presenting with as a chiropractor, you can say, hey, you know what? I'm also doing a neurological exam on you, and I've noticed that you've got some damage to your brainstem right here, and so we're going to go ahead and cause some neuroplasticity to happen there. We're going to activate that, and we're going to rebuild those pathways, and we'll just go ahead and do that every time you come into the clinic. And then just blow their minds with what you know about neurological and say, you know, we do treat more than just your neck and your bones. We actually are doctors of the nervous system.
When he's talking about cranial nerves 3 and 4, your eyes aren't at 23 degrees, so you are using superior oblique and inferior oblique to go up and down. So you've got a lot of inferior oblique, and keep in mind, like we said, or as he said at the very beginning, if your eyes are straight ahead, if it's not 23 degrees, you still have to incorporate a upward and downwards pull from both the oblique muscles to go. So you have that combination, and it's like he said, it's not necessarily the muscles that we're talking about cranial nerve 3 and 4, but where the nuclei are. You know, when you're thinking about upward movements and stuff like that, it's mesencephalic, because that's where the RIMLF is. And you guys can write that down and look it up if you don't know what it is. But horizontal movements is all pontine. So it's where you look at where you see 6, right? So that's pons. So that's the PPRF. So you're looking at stuff like that too. So in terms of brainstem, where you're checking.
Absolutely, absolutely. So that's why, you know, and it always brings back. I'll never forget. I was talking once with Dr. Mazvan and Cusano, and I think it was another doc. I think it was Dr. Hall, and we were in we were in FSA. And we just asked, we said, you know, why would a person that wants, you know, to have an awesome chiropractic practice, but see, you know, traditional chiropractic patients, why would they do all this neuro stuff as well? Because it's a lot of work. And their answer was all the same, all 3 of them. They said, because it will make you an incredible chiropractor. And this is one of the reasons why. You know, you're going to get whiplash patients like crazy, car accident patients like crazy, and you can own that. You know, I mean, that's an incredible chiropractor, where you can actually show them deficiencies in the brain as a result of that and take care of it. You know, and especially if they start to have all kinds of, oh, anyway, that's understood. Yes, absolutely. And remember, this is on the back of your page too, so I don't want you to get to.
Which one did you say was break and
Oh, yeah, no, I'm glad you asked that. Frontal lobe is gas, and this is actually important for a Marsman as well. Frontal is the gas, cerebellar is the brake. So just think my frontal lobe is my go. You know, I'm deciding to go. I'm deciding to go. And it's that cerebellum that likes to control things and make it nice and smooth and coordinated that goes, oh, stop it there, speed demon. You know? So that's how I remember it. And it's your opposite frontal lobe. It's the same side cerebellum. So this is nothing but rebellious. It's the opposite side. This is the gas. That's the conformist right there. That's the non-chiropractor right there. All right. This is the chiro. All right.
That cerebellum is comparing where it is compared to where it needs to be, right? So it's the thing that says that's far enough. So if it doesn't say that's far enough, or this is the actual place where we need to be, then your frontal lobe is going to shoot past it. If it's weak, right, and it's trying to say this is where we are, but it doesn't say that or it doesn't say it loud enough, you're going to overshoot it. But if it comes across too strong and it says, no, this is where we are, and it actually happens to where it overpowers the frontal lobe, it's going to, the position sense, it's called a central integrator. So it's not integrating the location. Or it might integrate the location too much to the point where it's a hypo.
Right.
So you can look at it 2 different ways. Either the cerebellum's too strong or the frontal lobe's too weak.
Off with that, when you're using the cool little tools that you bought. First off, you want to do what's called a direct and indirect light reflex. With the loop, what I'm going to do here is I'm going to take a light and where's my cell phone? So basically, I'm going to take a light, I'm going to shine it in one of his eyes, And what I'm looking for is I want to see if he's able, if when I shine that light in his eyes, that it's able to close. All right? If I don't get any response at all, that means his sympathetics are way too low. And I saw that just a couple weeks ago in clinic. If I get hippus, and hippus is where it can't hold it. I can't think of a good analogy. I'm trying to think of a hippie analogy, but you know, it just starts. It's like a hippie on drugs. All right, just strobe light. There we go. You know, it's starting to fatigue out. That's hippus. That's the nice fancy intelligent, smart word for it. But it's getting. That means your sympathetics are actually a little bit high. If it altogether just goes, you know, it holds it for like 2 or 3 seconds, then sympathetics are very high. When you do your neurologist exam, you time it. Because it's a great way also to measure progress when you're trying to calm down that sympathetic. You go, how long until those eyes finally fatigued and went, you know, and they couldn't hold it any longer, okay? Of course, there's metabolic things and stuff like that play, but we keep it simple. And then I like this one. Once again, you know, well, you're going to do a fundoscopic exam, and when you're looking in there, you know, he's got you looking for the optic disc and all that stuff. But here's the sweet thing that you can do as a chiropractor like crazy, all right? And if you do this with your patients and you start recording it, you can literally, this is a gauge, this is a window, you're actually looking at how sympathetically driven they are. And what you're looking at is the vein to artery ratio. And the more sympathetically driven they are, the more those arteries are going to clamp down and it's going to become smaller than the vein. It should be the same size. When you look in there, you should see the same size. These shouldn't be different like this. You should have the same size. But as they're becoming more sympathetic, these arteries are going to be clamping in because they're having higher blood pressure, and it's going to start becoming smaller in terms of the ratio. And so you'll look inside their eyes, and it's so obvious and it's so cool, and it makes you sound really smart with the patient. You're like, yep, we got a 2-to-1 ratio here, you write that down. Oh, 3-to-1 over here. But you're also able to see which side is more sympathetically driven or not. And you will always see this. It's amazing. I've seen 5-to-1 at Cerebrum. But almost all of our patients that are coming in with PTSD are at least 2 or 3-to-1. 2-to-1 or 3-to-1. And it's really obvious, guys. So easy to see. It makes you feel like a doctor.
Like you said too, that's brain tissue. So you're looking at the VA ratio in the eye is the same thing as the VA ratio in the rest of the brain on that side. So it's like, okay, well the VA, I don't really care about the VA ratio in that eye as much as that entire hemisphere of the brain.
Yes.
Right. So that's what we're looking at. We're like, oh yeah, we're looking at the VA ratio of the eye. To us, it means like that's the VA ratio or the sympathetic ratio of that left hemisphere. Or that right hemisphere, which is a big deal.
It's a really big deal. So you see which side of the brain is actually more sympathetically driven, which then tells you, you know, and man, if you can, and this is all stuff that you can talk to and show to your patient. And again, part of your, you know, if you notice we're getting checklist after check, and you begin to focalize exactly where you need to be applying your therapy. And then finally, the corneal blink reflex. This was a good way just to torture your patients. And actually, I was told Dr. Brown, the way he teaches it, actually, it isn't quite right. What you want to do is, you want to, I can imagine that. You want to have your patient look up and away, and then you actually want to touch them right there on the very, you know, right before, I'm forgetting the terminology, but right there on the corner.
He taught us that.
Oh, did he? Oh, okay. Thank you, Dr. Brown. You know, and they won't blink, you know, and they're like, yeah, I can stare right, you know, they're all proud of how much they can stare and not blink. That's bad. That tends to be, if it's decreased, their pons is not working well, so it's not going to be able to gate very well what's happening with the mesencephalon, that primal side. All right, so there we go. We just localized it once again. All right, so now I've done number 3. I figured out which parts of my brain is deficient, and those are actually some of your best tests for mesencephalon and pons. So that's why I really want you to own this material for those regions. Now I need to activate them, either in my clinic or send them home with exercises. Okay, so. What's happening here? Luke's mesencephalon is screaming and his pons isn't strong enough to stop it. So at this point, I'm going to say at this point, most adjusting is contraindicated. We got to get his brain healthy enough to where it can handle adjusting, and then we're going to bring the adjustment. All right. But at this point, it's contraindicated because his primary concern is an overactive region of his brainstem. Powerful stimulation of an adjustment, because no one appreciates the power of an adjustment like someone who works with neurologically fragile patients. It would be like throwing gasoline on a fire, and so that's going to burn out. Or make the mesencephalon start screaming even louder. Okay. If you don't believe that, we have students here that are veterans. They don't often share it, but I mean, you'll see when they get into the adjusting labs, some of them have to leave. They'll have panic attacks and they have to leave just from setups alone. And it's pretty sad. They're my heroes. There's quite a few of them. You just don't know they're around. All right. So how would I then treat that? Well, okay, ideally with something like, with something as severe as post-traumatic stress, ideally they could go to someplace like Cerebrum because there's a lot of things usually going on that are secondary to the mesencephalon and the pons. But let's say they don't have that kind of money because it can be pretty expensive. Then what can we do for them in my chiropractic clinic? And you can do a lot, and frankly, it'll be very effective. And it won't be ideal for handling a lot of the secondary stuff, I don't think. But hey, go for it. I will tell you right now what you would want to do. I recommend stimulating V2 and V3 to make their pons stronger. Again, we're talking about trigeminal nerve, cranial nerve 5, which goes to the pons. That's what I told you a moment ago. If they can't handle an adjustment because this is screaming too loud and this is too weak, and that adjustment goes through every bit of that, I'm going to sneak into it through the cranial nerves first until they can sustain the adjustment. Okay? And so I'm going to go into it. The way I'm going to do that is I'm going to take it and I'm first going to touch right beneath their zygomatic process. Right here is V2. Okay? And what I'm going to start doing at first, I know with PTSD patients, a lot of times they can't even handle much more than you just come in and you can start rubbing that nerve. You can start patting it a little bit. Okay? This alone is sending stimulation into the pons. Okay? And then once they can handle this, and the other place you can do this is on the tip of the tongue. Alright? And the anterior 2/3 of the tongue, this is for boards. Those of you trying board, we're taking pretty soon. Anterior 2/3 of the tongue is V3. Alright? So the sensory part of it. So you can actually feel yourself. I did this and I cavitate actually in my thoracics. But you start doing this. The next step is you can then use vibration. I'm gonna give you a cool little hack here on how to do this. Tell them to go to the pharmacy or go to the drug. I guess not pharmacy, we're chiropractors. Go to the grocery store and tell them to buy a vibrating toothbrush. Not the one with the little spinny head, but the one where the whole thing just kind of vibrates. And then vibration sense. Have them put it rest it underneath their zygomatic arch, and just let it sit there for a couple of minutes. All right? It does wonders for their pons. Okay? And you have them do that then for about a week or two. Okay? And I promise you, you will see this hero, begin to calm. The beast will begin to calm him. Okay? Now, ideally then, when you can handle it, is you then want to move on to electrical stimulation. All right? Where you could take, I would imagine, I know at Cerebrum we have a device that we can put right here, and we can begin to gradually turn it up and encourage those nerves to grow, and that neuroplasticity happens. And it's really neat to see it happen because they can start handling it at higher and higher settings. So this is working. The nerves are growing, new pathways are being formed, they're getting stronger, the pons is getting stronger and stronger and stronger. And but I would think you might be able to get creative with the TENS unit. You just might. Who knows? Or get creative with whatever stems that you're using within your clinic. A facial massage. There's the massage therapist speaking of. Brilliant. All right. Free on Monday, right? You're going to do it for everybody? All right. So.
For these, be very, 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 very careful. Instead of setting time limits, do it based on their metabolic threshold, because the metabolic threshold is the brainstem. So and we have doctors that are all over the country that do set time limits, and that's and they just walk away, right? You could fry them. So go in and so you guys know the simple things put a pulse ox on them, look for signs of fatigue, like Matt's already said. He hit all of them. Hippus, if they start getting tears in their eyes, whatever. That's when you know to stop. So when it's stuff like this, especially with a vet where it's fragile anyways, right? You don't want to overwork a fragile part of their brain. So
how long do you keep it on there? That's the question. That's the answer. You keep it on, and you don't. Okay, with the vets, they want to ramp. They want to go.
Yep.
And everybody does. I even know there's even staff I've talked to around Cerebrum that they're they were like, I tried putting this on, and I just went and turned it up to about as much as I could handle because I want all that stimulation. And but the reality is what we're trying to encourage the dendrites of these neurons to grow. And that's, if you want a plant to grow, do you water it a little bit over a long period of time, or do you go and then dump a big bucket of water on it once?
Dump.
Plastic plants is.
Well, that's you at the end, bro. But what you want to do is, because the problem is when you dump it on there, a lot of times you can burn out the neuron. All right, it's called transneural degeneration or something. It's pretty smart sounding. But what you want to do then is you just want to give that slight stimulation there, the electric stimulation, and you just want to go just until they reach the point of maybe their eye begins to water, there's a little bit of fatigue. But you'll be surprised at how quickly it gets larger and larger. Let me see what my dog's doing. Oh, about to take the dog home from the emergency room. Woohoo! Charcoal and fluids. Blood works okay. Praise Jesus. All right. So, also, adjustments are contraindicated typically in this situation at the begining. But I would go ahead and say, go ahead and do rib adjustments. Which, man, hello. I wish I'd been there to see that today. I was taking care of this. And you want to give them to do breathing exercises. I posted, there's a cool new tool that helps you with breathing awareness called Spire. And I posted about it on the Neuro Club, and it syncs up with your iPhone, and it actually tracks your breathing for the day, and it even gives you alerts on your iPhone whenever your breathing becomes shallow. And the idea is to retrain you to breathe deeply. And so it's just a sweet little thing. I'd love to, if I was doing in-clinic therapy for a prolonged period of time, I'd love to put that on every patient. So tell them to get one and get it home. It's not expensive. Also, you can do BEST or NET it can help with the memory trigger, and absolutely you can do that. But keep in mind that PTSD doesn't only happen when certain memories come to mind. It's a constant thing from a severe brain imbalance. So definitely, absolutely, go ahead and do NET to handle the memories that come to mind. But just keep in mind though that it's unfortunately because of the cortisol surge at the moment of that happening, the whole brain was shot out of balance, and it's not just memory connected anymore. But help them with that memory, absolutely. But just don't expect that to be nearly enough. I mean, it won't be. But it's definitely a help. So definitely do it. I got a problem with that. Also, take-home treatment. In this situation, memory games. Remember Sonic, or I might be showing my age here, but okay, hello. The Sonic game where you get the 4 lights, and gives you a red, blue, yellow. Simon, thank you. Sonic the Hedgehog. But Simon's a great thing because what you tend to find with your post-traumatic stress patients is they have difficulty with tracking memory, keeping things in their head in the moment, and so that's really helpful with that. Also, there's just great little memory board games where you got to flip the cards. I'll tell them go home and do that with your kids, and great family time, and you're training that. And say but spend some time doing that every day. Prayer and meditation, because what they really need to do is they need to learn to be aware of when the animal that's in them, and that mesencephalon, and you can work on gating that with their frontal lobe. Prayer and meditation, great way to do that. Okay, encourage them to do that. Once the pond is able to handle extensive periods of electrical activation, I would repeat the neurological exam, and then I would resume adjustments, assuming that we can't send them to a chiropractic neurologist, they just can't afford it. Resume adjustments to therapy the rest of the brain. So then once I got things calmed down, let's repeat the neurological exam, full one all over again. Let me see where else you're deficient. You're probably going to find some temporal lobe deficiencies, definitely frontal lobe deficiencies, and let's start lighting them up. All right. All right, let's laugh. We got a few more to kick here. We got 10 minutes. We're going to wrap it up. Parietal lobe. Parietal lobe is one of those things that there's a lot of ways to assess it, but there is one way into it through the eyes, and that's with horizontal pursuits. So the way you do that is you just do this, back and forth. Okay? Yeah, come on. Show you real quick. Just get it on film. Come on, Sally. And so you're just going to nice. You can start slow. Oh, yeah, that's fine. Wait, convergence. See?
Yeah, just make sure it's even.
Oh, there we go.
So upward movements are mesencephalic, right? So we don't want to make
Up
plastic eye movements high on a mesencephalic patient. So
There we go. And you can start slow, and then you double the speed. He's got some bumps. Right there. And then you can go twice as fast. And then double your speed again. There we go. And that's a horizontal pursuit test. Thanks. We're good. And so that's just, if there's bumps there, it's not smooth, it's not evenly yoked, that's ipsilateral parietal lesion, and a cool way to catch that, if you got a patient that's bumping into things, tripping a lot, falling a lot, assess that, and then you can therapy that. It could just be parietal, in fact, it likely is. All right, cerebellum. We already talked about that. It's the brakes. It's the conformist ipsilateral cerebellum. And then last but not least, OPKs. These are we're not going to, this is kind of the, you think about this a lot when you think about the eye exam. I don't want to hit it too hard. I really don't want to hit it today. I think it's more vestibular. Yeah, it's blue. I got that for you, sweetie. Alexis, I got it for you. We talked about this. But OPKs, it's called optokinetic strip. I think I said that right. Kinetics, and it's this right here. It's that alternating pattern. And it's like watching a train go by. But what you're doing is you're eliciting that nystagmus that we talked about earlier. I'd like to hit that with vestibular system more because, like I said, it is the result of perceived motion and activating activate at least the pathways for your vestibular canals. And I just wanted to kind of at least make you, that is part of your eye exam, but I think we'll hit that more a little bit later. It's a good way to assess that. There's other ways you can assess vestibular system too. All right, that's what I got. I think, let's see, did Bryce step out?
Yeah, right.
Oh, there you are. So Monday, I know right off the bat, we're probably going to, some things come to mind that we can do to take it to another level.
Really, all I'm